Our next speaker is Katarzyna Chawarska. Professor Chawarska received her clinical and research training at the Yale University. She works on the autism spectrum disorders, especially in area of early diagnosis and follow-up of infants at risk of autism spectrum disorders due to familial reasons, genetic factors, or perinatal or prenatal risk factors.
I also realize that this talk and the talk after mine is the only thing that separates you from this glass of wine you've been thinking about for a while. Amazing talks and very, very, very hard act to follow. And I'm really glad that I'm in the clinical or translational part of this conference because I'm going to talk about ways of trying to detect markers of susceptibility to one of the most complex neurodevelopmental conditions, which is autism. We'll talk a little bit about what autism is. Everybody knows what autism is, right? Everyone, have you ever heard about autism? Yes. And if you were not living under the rock, you heard a lot about autism in the past few weeks, right? So we're going to talk a little bit about what it looks like in very young kids and what can we do to try to detect the earliest signs and what they're going to tell us about the condition and hopefully treatment. So what is autism? It is one of many or several neurodevelopmental conditions along with ADHD, intellectual disability, stereotypic movement disorder. Onsets very early, and it's characterized by difficulties in social interactions and also an array of repetitive behaviors ranging from repetitive movements to repetitive thoughts and activities. It is one of the most prevalent neurodevelopmental condition. Recent estimates suggest that about 8% of 80-year-olds in the US carry diagnosis of autism. Like other conditions in this category, it's more likely to occur in males, and its symptoms change over time. So we see different constellation features in a 2-year-old, different in a teenager, and different in a 30-year-old being diagnosed with autism. It is also an incredibly heterogeneous condition. Its expression can vary tremendously in terms of IQ, from really profound intellectual disability to quite brilliant profiles, very profound difficulties in interacting with other people or actually being interested in interacting but lacking skills, having no capacity to communicate verbally or being very verbose. It's also a disorder that co-occurs with many other conditions. So children who have autism often have ADHD, may have anxiety and intellectual disability. Despite everything you heard in the past several weeks, autism is not caused by Tylenol. It is etiology of autism is extremely complex and very strong, with a very, very strong component involving genetic factors. So far, we really don't have biological markers for diagnosing autism. So in order to diagnose this condition, we have to rely very heavily on analysis of the behavior presentation of the children. For many years, autism was typically not diagnosed until children are about 5 or 6 or maybe even 7 years old, despite the fact that we actually knew from the very early on the symptoms are present much earlier, which meant that neither the children nor families were supported by medical and educational professionals for many, many decades. In the early aughts, our group at Yale and several other groups around the country, around the world, have started establishing first diagnostic clinics focused on children under the age of 3. And in the past couple of decades, we've moved tremendously in the domain of diagnosing or detecting kids early, diagnosing them and implementing treatment, with the goal of improving the overall quality of life of children and their families. It was a tremendous effort by our group, but also other groups, to establish reliable diagnostic criteria, to follow these children over time, to make sure that these diagnoses are actually stable, and that we are beginning to understand what predicts outcome and what individual kids may need in terms of treatment. However, all these studies have been conducted. Symptoms of autism typically are very, very difficult to detect before the age of 12 months. At around 18 months, we can usually diagnose autism pretty reliably in highly specialized clinics. But before the age of 1, there are really no symptoms of autism that we can detect by just sitting across from the baby and playing with the baby and trying to elicit some vocalizations or maybe reciprocal interactions. With the naked eye, it's really, really hard to see which child will develop autism. We call that stage, developmental stage, between birth and about 12, 14 months, prodromal stage of autism. Despite the fact that we cannot see any major molar behaviors that was suggestive of autism, there are many reasons, theoretical reasons, that suggest that the processes, biological processes that are involved in development of autism already are operating in the first year of life. And the question is, how can we detect them? What kind of measures can we use in order to capture them? This is a very important period for us developmentally, because this is the period when we can begin to detect markers which tell us which babies are susceptible or most susceptible to develop social difficulties that are relevant to diagnosis of autism later on. These kind of susceptibility biomarkers help us, on the one hand, to predict which children might be at the greatest risk of having some developmental difficulties in a given area. And also, if these biomarkers, if these marker tasks actually tap into some causal mechanisms or help us detect the causal mechanisms, this can actually revolutionize how we treat autism, because at that point we might be able to design new interventions which can target the condition as it emerges at the mechanistic level rather than on a symptom level. So I would like to talk about some of the work, very selfishly, about some of the work that we've done in my lab and also in association with other labs. And they are focused on two domains. One has to do with development of social attention, and the second with development of brain networks, which are designed by evolution to support development of social attention early on. Oops. Oh, there you go. That's a good slide. Sorry about that. So, so how can we study emergence of autism before the symptoms begin to emerge, right? How do we identify our participants? And one of the strategies is to find a population of children who, due to some factors, in our case genetic factors, have elevated likelihood of developing a given condition. In our case, we've been conducting studies on younger siblings of children with autism. In general population, the risk was about 3% of autism. Amongst younger siblings of children with autism, this risk is around 20% and can be even higher if there are additional risk factors within the family. So out of 10 younger siblings, 2 are very likely to have autism. About 3 or 30% are likely to develop something that we call broader autism phenotype, which are some features associated with autism, maybe social vulnerabilities, maybe some rigidities, language problems, which do not cross the diagnostic sort of criterion or severity to meet the criteria for autism, but they nonetheless can be clinically significant and impacting, and it would be nice to know which of these children will also develop similar such features, broader autism phenotype features. Now, what to target? What should we target if we were looking for susceptibility biomarkers? What should we study in these young babies? What makes most sense? It's not a benign question. Many questions have been asked and led to nowhere. Leo Kanner, this gentleman over there, is a psychiatrist who described the first 11 cases of autism in 1943. This is the first time when the term autism or autistic disturbance of affective contact was used as a way of describing a group of or category of patients with certain symptoms involving social disability. And Leo Kanner said, when he described the kids, he said something interesting. He said that these children, strikingly, were very inattentive, both in response to other people's faces, but also response to their voices, to their speech. Translating it into current language, this is something that we call social attention, which is the ability to prioritize from amongst tremendous number of stimuli we are impinging upon our perceptual system, stimuli which are very important for survival, for adaptation, for bonding, and social learning, which are faces, especially faces that are speaking. Our group has shown reliably across multiple methods and also cohorts that limited attention to faces, dynamic faces, especially of people who are trying to engage a child with using eye contact and using child-directed speech, is profoundly affected in autism. And it is indeed one of the best replicated biomarker, not only in toddlers, but also in older children with autism, as indicated by the work of the independent group Autism Biomarker Consortium for clinical trials. So we have a nice target. We have a nice target in kids who have autism. Now the question is, do babies, social attention is sort of begins to manifest itself already in newborns. So the question is, are the difficulties in social attention also present during the prodromal stages of the disorder? And in order to do that, we use eye tracking studies. I don't know how many of you work with eye tracking. Awesome. So one person, two people. So eye tracking measures are extremely versatile, have a long history, and they involve measuring various indices of the movements of the eye, including saccadic reaction time, fixation duration, dwell time, in response to a variety of cognitive, attentional, perceptual tasks. It's a very good way of telling what's happening in the brain in someone who cannot tell us otherwise. It's a very direct way of measuring how the brain processes what the incoming information. In the past, it was measured in a very painful way. But right now, we have a capacity to measure eye movements in children when they are just sitting remotely, when they are just sitting in front of the screen, or more recently, even when they are interacting with another person face to face. So we designed, a while back, we designed a task in which we wanted to study something that we call selective attention. In this case, we have a complex visual scene. There's a lady sitting. Her name is Auburn. She's a School of Drama student at Yale. Auburn is, sometimes she's talking to the viewer, sometimes she's ignoring the viewer and makes a sandwich, sometimes these toys are doing something. So it's a very complex visual scene which is supposed to kind of mimic what babies are encountering in the real world. And the idea is when and how they select for processing the face of the person amongst other highly competing stimuli. And this is This is an example.
Hi
She's
again, sweetie. How are you doing? Are you having fun? You look so cute today.
as she's speaking, as she's performing activity, you see these green dots. These green dots are point of regard of babies. They're typically developing. And you can see how attention is pretty consistent within this group, shifting toward the areas which are most informative within, and perceptually salient and most informative within a given context. What we did, we have shown these kind of stimuli to toddlers, and we found this performance on these tasks separate kids with autism from kids without autism in a very, very reliable way. And you know, this kind of task is important because without attention, there is very little learning. Attention, we say, you know, attention gates learning. Without looking at faces or being exposed to the learning opportunities that are within faces, kids may have difficulties learning about emotions. They have learning about social referencing, joint attention, speech processing. So there's a lot of cost, developmental cost, in not monitoring faces in the real world environment. So we took this task and we showed this task to infants. They were 6-month-old infants. Some of them later developed autism. Some of them later developed broader autism phenotype. And some of them were typically developing. And we also had a group of children who did not have a family history of autism. And what we found consistently across a couple of studies, that those with diagnosis of autism, can you see my pointer? No. Ah, yikes. Those who have autism, for some reason, this is in blue, this is in red. In the condition when someone's actually talking and trying to engage them, they spend less time monitoring faces. Already at 6 months, so this is a marker that's present there before behavioral symptoms of autism begin to emerge. So, so the next sort of question for us was, or the next line of research coming from this work, which we completed in the mid-teens of this century, so to speak, was to ask a question, you know, how do these deficits arise at 6 months, right? So we have a cohort of kids with some genetic risk factors, right, or actually factors that are associated with autism. We have a behavioral index, and so how do they get there, right? What is the path? And the path, of course, is the brain, right? Because this is the intermediary between genetic makeup and behavior. And so we decided to do a study on newborns and examine their brain connectivity, development of their brains and their brain connectivity, and to see if we can see any relationship between these, between brain connectivity and later outcomes. This work was done with my colleagues at radiology and pediatrics, Todd Constable, Dustin Scheinhaus, and Laura Ment. And the baby in the scanner is my granddaughter. So what we decided to measure was resting state functional connectivity. Is anyone familiar with that particular modality? Great. So resting state is great because we can study brain activation when babies are asleep, which is exactly what you want to do if you don't want them to move a lot. It's a safe, it's non-invasive, and very non-demanding kind of technique. And what's wonderful about this technique is that the brain networks that typically support a variety of sensory, motor, cognitive, attentional, executive function, salience activities when we interact with real world, the same networks also continue firing or co-activating. Nodes within these networks continue co-activating when we are asleep. So by studying these networks in babies, newborns who are asleep, we are able to estimate what is the level of maturation in specific networks of interest. We published recently a study that sort of shows that these networks, cortical networks, develop incredibly rapidly during this prenatal to postnatal transition. We studied fetuses as early as 30 weeks follow them into newborn period, 44, 45 weeks, and the Sicilians network, which is highly relevant to autism, and default mode networks. And we can see that this is a transition, prenatal to postnatal transition. The connectivity within these networks increases very dramatically, suggesting that these networks are optimized, evolutionally optimized, to prepare babies for a processing of the very complex world around them, a social world, and they are there ready when they really need them. They open their eyes and begin to interact with the world. So what we were interested in this particular study, which just came out, I think it's still warm, I would say. What we were interested in this study is a specific network. It's a social perception network, which was quite recently described. And it's a network that extends from primary visual cortex through medial temporal area, through the nodes within the superior temporal sulcus, posterior, medial, and anterior. This is in adults. This network is specialized in processing of dynamic social stimuli, dynamic faces, emotions, speech, gaze information. So all the things that we are interested in, right? We contrasted connectivity within these pathways with another pathway that also concerns faces and involves fusiform gyrus. However, that area or that pathway is more likely to be associated with processing of face identity as well, and typically with processing of static faces. And so we evaluated these networks actually in two samples. We wanted to have a replication, nice replication. So one sample came from the UK, from Developing Human Connectome project with over 300 babies. And then we replicated it on our own sample at Yale. And on a subsample, we have data at 4 months, which captured social attention in these babies. And it was quite wonderful to see that these very important for social processing networks are actually positively, they are already co-activating. The nodes within these networks are co-activating very strongly, both on the left and right side, and also in the social perception network and also ventral network involving fusiform gyrus, which makes perfect sense. I mean, babies really begin to interact with faces very shortly after birth, and they are super important for bonding. A similar pattern, not identical, but similar pattern was also revealed in our smaller sample at Yale. But the most interesting finding from the study was that when we correlated the strength of connectivity within each of these 4 networks, right, the 2 social, left, right, 2 ventral, left, right, with attention to faces in the paradigm that I described to you, we found a very strong, quite robust relationship between right social STS and looking at faces at 4 months, but not in the other networks. There was close, but no cigars. So this was the first demonstration ever to show that, first of all, that particular network is active shortly after birth, and 2, that connectivity within this network predicts later social attention. Not shown here is that, and we have this data from this study and much larger study, that looking at faces at 4 months is highly predictive of lower autism severity later on, and also better social and communication adaptive skills. So, to sum up, this line of work has shown that attentional vulnerabilities, social attention vulnerabilities, are the kind of biomarker that cuts across age, cuts across the prodromal and syndromal stages of the disorder, which is quite remarkable. And we also demonstrated that identify a network that's not only active at birth, but it also predicts later strength of connectivity and these associations of clinical meaning, because then they translate or cascade into social functioning later on. These are really fresh findings, so we are working on optimizing the measures and enhancing these effects. But this kind of work has a number of, I hope, potentially important translational opportunities. First of all, combined with another study, which I don't have time to go into, we have identified a window before 6 months. Most studies on baby siblings start at 6 months, but we identify a window before 6 months as an important window of opportunity for detecting individual differences that predict social outcomes in infants. And these outcomes are truly relevant to autism. These are associations. We have not been able to establish the mechanistic or causal sort of relationship between these measures. But if we do, we can start thinking about targeting some of these social precursors of social attention as a potential target for preventative treatments for social difficulties in autism, but also in associated conditions. And hopefully this information also, especially the imaging information, will feed back to genetic studies, hopefully informing opening new opportunities for detecting genetic markers associated with this particular difficulties. So this work would not happen without hundreds of parents and their kids who have been coming through our lab in the past 25 years. Many funding agencies. Amazing team, my group, and also amazing collaborators, both at Yale and also outside Yale, which make this work all possible. And I want to thank you for your attention. You have only one more talk before you can get a drink.